P trial and extrapolated it to include PO glyburide. Both of these studies included patients who were 18 years and older with moderate to severe stroke. The Huang and colleagues trial gave PO glyburide as 1.25 mg followed by 0.625 mg every 8 hours for 5 days. And in this trial, they did not see significant improvement in the modified Rankin scale score at 6 months. However, their matched cohort did suggest that administration of glyburide was associated with lighter brain edema. In the second trial by Wilkinson and colleagues, they gave glyburide as 2.5 milligrams twice daily for 72 hours. They categorized patients as those who received partial duration or 1 to 4 doses and those who received a full duration, which was anywhere between 5 to 7 doses. And this trial actually did not see differences in the rates of intervention for cerebral edema, whether patients received the partial or the full duration. However, they did note greater rates of hypoglycemia in the patients who received the full duration. So, taking all those findings, we still have an unclear assessment of the true efficacy of IV glyburide in cerebral edema. So, the CHARM trial took place and looked at patients with large hemispheric infarcts and assessed whether IV glyburide really improved functional outcomes at 90 days. This was a phase 3 double-blind, placebo-controlled randomized trial conducted across 143 stroke centers in 21 countries. They included patients who were 18 to 85 years old with a large stroke in at least the middle cerebral artery territory and presented within 10 hours of symptom onset. Patients had an NIHS score of 10 or greater, a core lesion volume of 80 to 300 mils on CT perfusion or MRI, or they had to have an aspect score of 1 to 5 involving at least 2 cortical regions. For any patients who received thrombectomy, they were required to undergo post-thrombectomy MRI. And this study allowed a maximum of 20% of the patient population to be treated with thrombectomy due to the changing standard of care. Patients were excluded if they received decompressive craniectomy prior to enrollment, had evidence of herniation, brain hemorrhage, or if they received intraarterial thrombolytic agents. Patients who received IV glyburide, it was given as 8.6 milligrams over 72 hours, and again, this was given up to 10 hours after stroke onset. Unfortunately, this study was terminated early because of slow enrollment due to COVID-19. For the study outcomes, the primary efficacy outcome was a shift in the distribution of the modified Rankin scale scores at 90 days. They also looked at secondary efficacy outcomes such as 90-day mortality, the proportion of patients with a modified Rankin scale score of 0 to 4, and midline shift on neuroimaging at 72 hours. Secondary safety outcomes included incidence of serious adverse events, as well as clinically significant abnormal vitals or lab results. For the statistical analysis, with their primary efficacy analysis, this was pre-specified to patients aged 18 to 70 years who received any study drug with at least one post-baseline modified Rankin scale score before day 90. And they capped the age at 70 years due to findings from previous literature that suggested higher mortality in patients over the age of 70 years due to withdrawal of care. Other items related to the primary efficacy analysis, they use an ordinal logistic regression and they adjusted for baseline randomization. For the safety analysis, they included the patients up to 85 years of age and also adjusted for the baseline randomization. Now moving on to the results of the CHARM trial. So there were initially 535 patients that were randomly assigned, 267 of which were assigned to the study drug. 259 of those patients were actually given the IV glyburide, and 217 of those patients were included in the primary efficacy analysis. As for the baseline characteristics for the primary efficacy group, we see that it's largely comparable between the placebo and the IV glyburide group. The pre-stroke modified Rankin scale score was between approximately 40% had a score of 0, and the score for NIHS scale was 19 in both groups, and about 40% of patients received alteplase. Additionally, similar rates of endovascular thrombectomy and rates of reperfusion were present in both groups. As for the enrollment imaging modality, we see a similar distribution of modalities between both groups as well as the core volume. There's also similar efficacy or similar rates of the stroke onset to alteplase administration, arterial puncture, imaging, randomization, and the start of the study drug. For the results itself, the primary efficacy did actually not reach the significance. There was no difference in the median modified Rankin scale score at 90 days. Approximately half of the patients in both the placebo and the treatment group had a median modified Rankin scale score of 5 to 6. For the secondary efficacy outcomes, there was also no difference in the mortality, the modified Rankin scale score of 0 to 4 at 90 days, as well as the midline shift. And of note, the midline shift measurements were not available in about 30% in both groups, and this more frequently affected patients with more severe stroke, as defined by a higher NIHS score and the ischemic core volume on imaging. For the safety outcomes, we see similar rates here with slightly greater risk of serious adverse event of hypoglycemia in the treatment group, which is not unexpected. We also see similar rates of decompressive craniectomies in both groups. So although the primary efficacy for modified intention to treat group was not very significant, the authors did conduct a subgroup analysis which signaled potential benefit in patients who underwent reperfusion therapy with thrombectomy or alteplase administration, and those who had an NIH score of 20 or lower. There was also a potential signal for efficacy in patients who presented with wake-up stroke. Now, to further add on to the primary efficacy outcomes, they also performed a post hoc analysis of the baseline stroke volume. Essentially, a adjusted odds ratio of greater than 1 signals benefit, and this post hoc analysis suggested that patients who presented with a baseline stroke volume of 125 milliliters or lower were thought to benefit more so from the IV glyburide. As for strengths and limitations of this trial, this was a multi-center trial that investigated the role of prophylactic cerebral edema therapy with IV glyburide with a large heterogeneous patient population and didn't impose the same restrictions on standard of care as seen with our previous trials. It also included patients with a large core stroke volume. As for limitations, as I mentioned earlier, they were missing data for midline shift measurements in about 30% of each the placebo and the treatment group, and this was seen more frequently in severely affected patients. And unfortunately, because it was terminated early, they only achieved 70% of target enrollment, and this was an underpowered study. From these findings, the authors concluded that IV glyburide did not reduce disability at 90 days in patients with large hemispheric infarcts based on a shift analysis of the modified Rankin scale scores. They did note, however, there may be a trend towards favorable outcomes dependent by the baseline infarct volumes and those who underwent reperfusion treatment. Some key takeaways from this CHARM trial is that we see that the survival benefit and reduction of midline shift was not replicated in CHARM, as we saw with the pilot study and the GAMES RP trial. However, the overall neutral results may be due to a shift in the standard of care for cerebral edema and varying practices across sites. When this trial was first started, the use of thrombectomy was not commonplace. However, as they started to enroll more patients, they actually extended the cap from 8% to 20% of patients being allowed to receive thrombectomy due to the shift in the changing practice. And lastly, the baseline lesion volumes and the use of endovascular therapy may be helpful in determining the efficacy of IV glyburide in patient populations who may really benefit from this treatment, as seen with the subgroup analysis and the post hoc analysis.
Thank you, Julie, so much for your presentation. So, everybody, as you all are have finished listening to her presentation, if you have any questions for Julie, please put them in the chat, or if you want to unmute and ask them yourself, that's totally fine. Julie, while we are waiting on some other questions, I had a few questions in terms of it was, stopped early. And I know that you mentioned that part of it was COVID-19 pandemic and enrollment stuff. It also looks like they had a lot of missing data from midline shifts as well. Do you have any comments about that? Did they have any better explanation about why they were missing that data? And since it looked like it was almost 30%, I think, that they were missing.
Yes, so unfortunately, I did not see a clear-cut reason as to why that data was missing, and I also thought it was interesting, which is why I explicitly pointed it out as I was going through the data. Unfortunately, I do think the fact that this trial was underpowered and the missing degree of midline shifts makes it harder for us to really assess the true efficacy of IV glyburide in these patient population.
Okay, you have Andy has a question in the chat. Do you think there's a population where oral glyburide might have a role in cerebral edema?
Again, glyburide is a fairly benign medication, and I know some sites have already adopted this practice. As seen from the results of this trial, I think it would be reasonable to consider in patients who present within that 10-hour window frame from symptom onset, who have an ischemic core volume of 125 mils or less, and otherwise fit the criteria for the trial. If hypoglycemia is a concern, there's always an option to administer dextrose concomitantly, and frequent blood glucose checks as well.
I think it's interesting, Julie. I don't know about your institution. I know my institution has taken sulfonylureas off our formulary in general, just in terms of diabetes management. So I'm curious. I put that in the chat if anyone is regularly and routinely using glyburide for this indication. Jake, do you have a question or
Yeah, I have a
go,
question.
go for it?
Really, I was curious to see what your thoughts were on, looking at this patient population in large hemisphere infarctions. Were you surprised to see these high modified Rankin scales in this patient population? And if you were to redesign this study, would you look at patients with moderate or less severe strokes with this same primary outcome?
Yeah, thank you for your question. I don't find it very surprising. It's unclear whether these patients, again, the ones with worse or higher modified Rankin scale, had malignant cerebral edema, or if the core lesion volume directly correlated with the modified Rankin scale score, which I would assume some level of correlation. I do think it would be interesting for future studies to go extrapolate from the post hoc analysis and stratify patient populations based on different cutoffs of the lesion volumes.
Yeah, I would agree. I think really that missing data that we're miss or would really like to see in this study is the midline shift data. I'm really not surprised that these large hemisphere strokes all have a lot of very high modified Rankin scales, but it'd been very cool to see that midline shift data.
Thank you, Jake, and then thanks, Julie, for answering that. Do we have any other questions before we move on to our next presenter? Okay, thanks so much, Julie. Kate, if you want to go ahead and you can turn on your camera and share your screen, let me know if you have any issues getting it shared. Okay, that looks perfect, and you can go ahead and start when you're ready.
Thank you so much. Okay. Hi, everyone. Again, my name is Kate Harding. I'm a PGY2 critical care resident at the Ohio State University Wexner Medical Center. And this is my presentation, Taste Test, Sublingual Edaravone Dexbornial for the treatment of acute ischemic stroke, the TASTE-SL randomized clinical trial. These are just some abbreviations that I'll be using throughout the presentation today. And to jump into our background information, so acute ischemic stroke results in the activation of the ischemic cascade. So with our stroke, we have focal cerebral hypoperfusion that results in excitotoxicity, which contributes to oxidative stress and post-ischemic inflammation, further contributing to microvascular injury, blood-brain barrier dysfunction, cell death, and ultimately cerebral damage. The Stroke Treatment Academic Roundtable is a yearly conference that is a collection of top-tier global experts who meet to evaluate barriers and opportunities for advancement in acute ischemic stroke management. And in recent years, advancements in the research and application of brain cytoprotective approaches have been a focus, given these agents have the ability to reduce ischemic injury via pleiotropic effects over various targets. Historically, there has been an absence of strong evidence supporting efficacy of most cytoprotective agents, including agents such as magnesium, uric acid, albumin, and natalizumab. However, edaravone and dexbornial are agents that have demonstrated significant cytoprotective activity. Edaravone is a free radical scavenger and an inflammatory protein expression inhibitor. This was actually developed in the late 1980s with the specific intention for use in the acute ischemic stroke population and was first approved for acute ischemic stroke in Japan in 2001. In the US, it is not FDA approved for acute ischemic stroke, but it is FDA approved for the prevention of progression in patients with ALS. Dexbornial, on the other hand, is a historic herb in Chinese medicine. It inhibits inflammatory cytokines and proteins such as TNF-alpha, IL-1 beta, COX-2, and inducible nitric oxide synthase. And it also activates GABA-A receptors, so it helps reduce that excitotoxicity we see in the ischemic cascade. Dexbornial is also highly lipophilic, so it readily crosses the blood-brain barrier, but it also enhances the blood-brain barrier permeability through various mechanisms, which may allow for easier penetration of other agents. And together, these agents are thought to have synergistic effects on brain cytoprotection. For some of our evidence regarding edaravone and dexbornial use in this population, it has been well established that there are improvements in functional outcomes seen with edaravone. Otomo and colleagues evaluated edaravone 30 milligrams twice a day for 14 days compared to placebo and found significant improvement in the modified Rankin Scale scores at discharge or 3 months with edaravone. Similarly, Wada and colleagues evaluated the same regimen in patients who received thrombolytic therapy and also found improved outcomes at discharge in patients who received edaravone. Lee and colleagues conducted a systematic review to evaluate the neuroprotective effects of Borneol on the ischemic cascade and found that Borneol prevented neuronal injury, transported endogenous nutritional factors through the blood-brain barrier, and promoted passage of other drugs through the blood-brain barrier. When comparing edaravone monotherapy to edaravone and dexbornial in patients with minor to severe stroke, the TASTE trial found a significant improvement in functional outcomes at 90 days. And lastly, preliminary data from the TASTE-2 trial suggests that edaravone dexbornial use resulted in significantly more functionally independent patients compared to placebo. For some background on our sublingual formulation, so looking at the pharmacokinetic data, bioavailability studies in animal models have found that there's about 70% bioavailability with edaravone compared to 85% dexbornial with the sublingual formulation. And then I listed some PK parameters that were evaluated in both the edaravone sublingual formulation as well as the edaravone IV formulation, both 30 milligrams after a single dose. And as you can see in each of these PK parameters, they're actually pretty comparable between the two formulations. Additionally, I wanted to highlight some of the benefits of the sublingual formulation, including rapid absorption and the lack of need for IV access, which can allow for a quicker time to administration, as well as the ability to administer this agent out of hospital. So although these trials have demonstrated that IV edaravone dexbornial provided rapid cytoprotective effects, it's unclear if these effects can be replicated with the sublingual formulation. So the TASTE-SL trial aimed to evaluate the impact of sublingual edaravone dexbornial on 90-day functional outcomes in patients with acute ischemic stroke. For the methods of this trial, this was a phase 3 double-blind placebo-controlled parallel group randomized controlled trial across 33 centers in China from June 28th of 2021 through August 10th of 2022. Patients were randomized 1-to-1 to sublingual edaravone dexbornial, 36 milligrams, which consisted of 30 milligrams of edaravone and 6 milligrams of dexbornial, compared to placebo, which was a formulation of 0 milligrams of edaravone and 60 micrograms of dexbornial, each of these twice a day for 14 days. And I did want to note that patients in the placebo group received this small dose of dexbornial with the purpose of simulating the cool taste of sublingual edaravone dexbornial. However, this is 1/100th of the dose of dexbornial compared to the dosing used in combination with edaravone. So I would not expect this to be a clinically significant amount of dexbornial. For the inclusion criteria, they included patients age 18 to 80 years old with an NIHSS of 16 to 20, so moderate to severe stroke patients, with a total motor deficit score of the upper and lower limbs of 2 or greater, having a diagnosis of acute ischemic stroke, randomized within 48 hours of symptom onset, and then having a modified Rankin Scale score of less than or equal to 1, so having no symptoms or some symptoms but no significant disability prior to their acute ischemic stroke. Some of their notable exclusion criteria included ICH seen on imaging, severe disturbances in level of consciousness, which was classified based on the component of the NIHSS score evaluating this of a score of greater than 1, having a transient ischemic attack, a systolic blood pressure of greater than 220, or a diastolic blood pressure of greater than 120 following attempted blood pressure control, having severe mental disorders or dementia, severe liver or kidney disease, renal insufficiency, or acute kidney injury, the use of other neuroprotective agents after acute ischemic stroke, embolectomy or interventional therapy, which they classified as intra-arterial thrombolysis, mechanical thrombectomy, angioplasty and stent implantation, and malignant tumor or patients undergoing anti-tumor therapy. For our outcomes, the primary outcome is the proportion of patients with an MRS score of less than or equal to 1 on day 90 after randomization. Secondary outcomes included MRS scores on day 90, the proportion of patients with an MRS score of less than or equal to 2 on day 90, change in NIHSS score from baseline to day 14, and the proportion of patients with NIHSS of less than or equal to 1 on days 14, 30, and 90. And then they also evaluated safety outcomes, including adverse events, treatment-related adverse events, and severe adverse events, which, to note, the most common adverse events reported with edaravone were are bruising, abnormal gait, and headache. And in the phase 2 trial evaluating IV edaravone dexbornial, the most commonly reported adverse events were pruritus, skin rash, acute liver injury, and kidney injury. And their last safety outcome they evaluated is the change in vital signs in lab data before and after treatment. In the statistical analysis, the authors estimated they would need 457 patients in each group to be enrolled in order to achieve 80% power. And this was based off the estimation of 50% of the sublingual edaravone dexbornial group and 40% of the placebo group having an MRS score of less than or equal to 1 at day 90, which was comparable to the estimations and results found in the TASTE trial as well as the TASTE-2 trial. This 457 patient calculation also accounted for a 15% dropout rate. All of these analyses were performed in the intention to treat population. Continuous variables were assessed via Wilcoxon sign rank test. Categorical variables were assessed via chi-square or Fisher's exact test. And the odds ratio for the primary and most secondary outcomes were conducted via logistic regression, with the exception of changes in NIHSS score from baseline to day 14, which was evaluated via ANCOVA. And all of these statistical tests utilized were appropriate for the intended variables. The authors also conducted a post hoc sensitivity analysis to impute missing data for the primary outcome and assess for heterogeneity of treatment effects on the primary outcome conducted in pre-specified subgroups via logistic regression model. Looking at our study population, 956 patients were assessed for eligibility, 42 of these patients were excluded, leaving 914 patients being randomized. This included 450 patients in the sublingual edaravone dexbornial group, and then 464 patients in the placebo group for our intention to treat population. And I did want to note that 121 of these patients did not complete the study per protocol, which is about a 13% dropout rate of patients in each group. These patients were commonly excluded due to early discontinuation of trial treatment, being lost to 90-day follow-up, or needing a prohibited concomitant medication, such as drugs with an indication in their package insert for neuroprotection or cerebral infarction. Looking at our baseline characteristics, as you can see between edaravone dexbornial group and the placebo group, these are overall very well balanced. Some notable characteristics I wanted to mention were the age with a median of 64. The majority of the patients are male. The median NIHSS score of 7, indicating most patients had moderate stroke. And then looking at our TOE subtype, 54% had large artery atherosclerosis and 40% had small vessel occlusions. For the primary outcome of an MRS score of less than or equal to 1 on day 90, this was achieved in 64% of patients in the edaravone dexbornial group compared to 54.7% in the placebo group, which was statistically significant. In the subgroup analysis, edaravone dexbornial was favored in the overall group, and no significant interactions were detected for any subgroup, which was stratified based off age less than or equal to 65 compared to those greater than 65, gender having an NIHSS of less than or equal to 7 versus greater than 7, the past medical history that was noted in the baseline characteristics, TOE subtype, and severity of kidney impairment. And the sensitivity analysis, which again was based off models for imputing missing data, edaravone dexbornial was favored in every scenario, which included best case analysis, worst case analysis, last observation carried forward with the best case analysis, last observation carried forward with the worst case analysis, and adjusting for location and time to randomization. For the secondary outcomes, the only significant secondary outcome was MRS score on day 90. And as you can see, the edaravone and placebo groups both had a median score of 1. However, if you look at the interquartile ranges, edaravone dexbornial had an interquartile range of 0 to 2 compared to placebo, which was slightly higher at 1 to 3 and was found to be statistically significant. Looking at this graph below to kind of summarize some of this significant secondary outcome findings as well as the primary outcome, this is a shift analysis of your MRS score with edaravone dexbornial on the top and placebo across the bottom. And as you get darker in color, it's an increase in MRS score. So similarly to the primary outcome findings, the biggest difference between the groups is in patients with an MRS score of less than or equal to 1. And the difference in the total percent of patients between group narrows significantly when you look at patients with an MRS score of less than or equal to 2, making that difference no longer statistically significant. For these safety outcomes, there's no difference between groups in adverse events with 90 days, treatment-related adverse events within 90 days, or serious adverse events within 90 days. And they also did not note any significant differences in any vital sign or collected laboratory values between groups when obtained at their 90-day follow-up. To summarize, this is the first brain cytoprotective agent to be administered sublingually to patients with acute ischemic stroke. Administration of sublingual edaravone dexbornial resulted in minimal serious adverse events and comparable safety to placebo, and sublingual edaravone dexbornial demonstrated brain cytoprotective effects. The authors concluded that in patients treated within 48 hours of acute ischemic stroke onset, sublingual edaravone dexbornial improved 90-day functional outcomes compared to placebo. Some of the strengths of this trial included the study design, again, it being across multiple centers, being placebo-controlled and randomized, and also double-blind with a very thorough blinding process. The baseline characteristics between groups were very well balanced, and this study had a relatively large sample size that has been previous to similar trials evaluating this agent, and also allowed them to achieve adequate power. There are also several limitations to this trial, the first being that the authors did not compare IV and sublingual formulations. So it's unclear how these compare in terms of their effects on functional outcomes. Although, as noted at the beginning of the presentation, it appears that they do have similar PK findings between the formulations. Another limitation would be the generalizability. All patients were of Chinese Han ethnicity. Again, the median age of 64 and being mostly male patients. They only used an MRS score to evaluate functional outcomes. And although this is a very common marker of functional status, they did not really evaluate quality of life or cognitive function, whereas other trials assessing neuroprotective agents have used tools such as the Montreal Cognitive Assessment, the Barthel Index for Activities of Daily Living, and the Stroke Impact Scale. As mentioned earlier, this was only conducted in the intention to treat population. So although this may make it more generalizable, 121 patients did not complete the study per protocol, and this resulted in a lot of data having to be imputed for them. Although I did want to note again that the sensitivity analysis evaluating this imputed data, edaravone was favored in each method of data imputation. There's no report of study drug adherence. So the authors did propose a method in their Appendix 1 about how they were going to track study adherence. However, they did not report any of this data, so it's unclear if they were actually assessing compliance to the study drug in the outpatient setting. Additionally, patients enrolled had a low median NIHSS, so this is not necessarily representative of patients with mild or more severe stroke population, and the authors did note that this may have been a significant contributing factor to the lack of statistically significant secondary outcomes. Furthermore, they excluded patients who underwent endovascular therapy, so this subset of acute ischemic stroke patients is not well represented, and the utility in this population is not clear, although it may likely be more beneficial anyways in the patients who receive thrombolytic therapy, as patients who undergo thrombectomy may have better outcomes. But with that, they did include patients who either had no intervention or could receive thrombolytic therapy, but they did not report how many patients in each group received thrombolytic therapy, nor if it was appropriate utilization of treatment. So it's unclear how this could have impacted the study outcomes. And lastly, the study was funded by Simcere, who is the manufacturer of sublingual edaravone dexbornial. And the study did state that the funders did not have any involvement in the trial design or analysis. However, several of the authors are actually employed by Simcere. So what does all this mean in the relevance to practice? Sublingual edaravone dexbornial improved functional outcomes, was safe compared to placebo, and the sublingual formulation is quickly absorbed and gives us the potential to administer this out of hospital. So at face value, you would think this is great. We should administer this to all acute ischemic stroke patients given the potential benefit and minimal serious adverse events. But based off of this study, I would not currently recommend this in standard practice for acute ischemic stroke management. Again, this is only studied in one ethnic population. It did not include minor or more severe stroke patients. The majority of patients are male and of older age. It's unclear if appropriate acute ischemic stroke treatment was utilized and how this could have contributed. And they did not include patients who underwent thrombectomy. So for some of our takeaway points, this was a well-designed study with similar findings to those of previous trials, TASTE and TASTE-2, evaluating the use of edaravone dexbornial in this population, and it appears to be safe and effective in improving functional outcomes. Regarding the clinical applicability, this is a promising intervention for patients with acute ischemic stroke, but more data is needed to support widespread use. How would this impact institutional practice? I don't think this would currently impact institutional practice, but it has the potential to be implemented into usual care for acute ischemic stroke patients pending further data. And actually, this study has led to the FDA breakthrough designation approval for sublingual edaravone dexbornial. So hopefully with this being expedited in development and review, we can see some more studies coming out with this in broader populations. That takes us into our next steps. So evaluating and expanding research to other ethnic populations, stroke severities, ages, more equal distribution in gender, and endovascular treatment. I also would like to see studies conducted and have subgroup analysis based on the acute ischemic stroke management strategy, so no treatment compared to thrombolytic therapy versus endovascular therapy, and also looking at the optimal timing of administration. So as we know, time is brain, so does this earlier implementation of this drug potentially have greater benefits versus later? These are my references, and I will happy to take any questions. Thank you guys so much.
Thank you, Kate, so much for your presentation. Both you and Julie did a great job. Does anyone have any questions for Kate that she could answer about this new promising option in acute ischemic stroke? So Andy's question is, I'll read out for everybody. Did the authors comment on why they did not describe thrombolytic use?
They did not comment. Yes, agreed. Does seem like a miss during peer review. Yeah, they did not comment on it, and I looked through the appendices multiple times to see if they made a note of it. Unfortunately, they did not have any information as to why they did not describe the initial stroke management strategies for these patients, but definitely that is, as I mentioned, a severe limitation of this trial.
And a great thing that you pointed out during your journal club. Okay, what other questions do we have for Kate? Kate, I have one. In terms of the outcomes, it looks like if the modified Rankin was missing, there was a group of patients that they assumed it to be 6 if they had one post-baseline measurement of modified Rankin, or if they discontinued treatment or were lost to follow-up, they were automatically given a 6 on the modified Rankin. I know they did a sensitivity analysis. Do you have any thoughts about those patients being given a modified Rankin of 6?
I think definitely, obviously, that is like worst case scenario for these patients. So I do think if they had not conducted the sensitivity analysis where they implemented these various different scores, so not only did they like assign them 6, but they also assessed patients where they implemented best case scenario. So I would say it would have been a stronger limitation and much more concerning if they hadn't evaluated the other potential outcomes in that. But I think, like I was saying, with there being so many patients in each group who did not actually end up completing per protocol, that would kind of is another like confounding factor as to like potentially having this data imputed instead of having the actual numbers.
Great, thank you. What other questions do you all have for Kate? One other question that I could think of, Kate, is when I was pulling up the supplemental stuff as you were talking, and it seems that it was when they talk about concurrent medications that were received, it was very generic, that they didn't really have that much info about those medicines. Is that what you found as well?
So I ended up finding the supplemental. They had a very extensive list of different agents. So as far as like neuroprotective agents, some of the ones that we'd be more familiar with would be like edaravone. They also excluded patients who received nimodipine. Otherwise, there is a lot of interesting other agents that were in there that I'm not sure are actually utilized in the US. And then as far as like indications for cerebral infarction, I was not familiar with any of the agents that they had listed. And there's several like herbal agents as well. So I'm thinking most likely these are probably more common in the Chinese population and things that they have approved over there. But yeah, those are the only two that I really noted. Besides, they also mentioned mannitol for neuroprotection rather than reducing ICP, but those are the only 3 that I think were actually familiar or utilized in the US. Yeah.
Perfect. Andy put another a question in the chat. With the breakthrough designation that you mentioned towards the end, do you know if an international trial is going to be conducted or if it's planned? Did you see anything about this?
So I was looking into this. I did not see anything as far as like on the clinicaltrials.gov if anything is in the works, or I couldn't find any other reports of a potential international trial, nor one being conducted in the United States alone. But I think, again, expanding that to a much broader population would be really significant for the utility of this drug.
Jake, go ahead if you have a question.
Yeah, absolutely. Good presentation, Kate. I was looking at the baseline characteristics between both of the groups and the TOAST criteria of the stroke etiology. And what do you think about the primary stroke subtype being large artery athero, and then looking at the incidence of cardioembolic strokes? Is this relatively one ethnicity Chinese population similar to the patients you see in the neurocritical care units in terms of etiology?
I would say that I feel like in the neurocritical care unit, in my limited 2 months experience, that I've seen a pretty general mix of both of those. I feel like we have several patients who do have a cardioembolic indication as well as like the atherosclerotic indication. I think that there was probably a lack of patients with cardioembolic stroke in this study. They had one of their exclusion factors of being able to receive anticoagulation or antiplatelet therapy. So I don't know if that upfront remove these patients or if it is a difference in population, but I do think that's another limitation is not evaluating that in this population.
Okay. Any other final questions or thought before we wrap it up a little bit early? Well, let's give Julie and Kate a round of applause. You guys both did a great job. And thank you for everybody for tuning in today for our Pharmacy Journal Club. Hope everyone has a great rest of your Mondays, and we'll see you next time, okay?